someone may say, well, you don't have SIBO, therefore you don't have to go low FODMAP. And oh, what a miss that would be, because in this study, it wasn't dependent upon SIBO status. It was dependent upon severity of IBS symptoms that predicted who would respond better to a low FODMAP diet. Hey everyone, welcome back. This is Dr. Michael Ruscio, DC. I am a practicing clinician, a clinical researcher, and an adjunct professor at the University of Bridgeport. And if you're like me, you appreciate how important science is in informing your healthcare decisions. With that, let's cover a number of studies published in the realm of IBS, SIBO, and gut-directed therapeutics, what they found, and how we can use them to make better healthcare decisions. So let's go into a quick overview. We'll discuss the microbiome, how this correlates with IBS subtypes. Does breath testing predict who will respond to a low FODMAP diet? So does having a SIBO diagnosis tell you if you should or should not go low FODMAP? Great study there. We'll compare low FODMAP to IBS medications, look at an association between IBS and look at how we can improve post-infectious IBS, and then look at a correlation between PTSD or post-traumatic stress disorder and IBS. And then also look at if vitamin D will improve IBS. And this is actually a meta-analysis, so we'll examine there. Then we'll pivot over to SIBO and discuss, do SIBO patients experience more negative emotions? Additionally, are SIBO and H. pylori associated? The prevalence of SIBO in various conditions, this is a very telling study. The connection between SIBO and liver conditions. And then finally wrap up with who benefits from bile acid sequestrants and how do acid-lowering medications impact children and their mental health. And final study will be on abdominal massage and its ability to improve constipation. So a lot here to unpack. Let's jump right in. Okay, the IBS studies. This first study wanted to examine if different microbiome profiles are associated with different IBS subtypes. Observational study, about 900 participants and 900 controls, all undergoing PCR stool testing. Now, compared to controls, the IBS subtypes had increased Escherichia and Shigella and reduced bacterial diversity. So IBS-D and IBS had different microbiota profiles. This led the researchers to conclude these findings highlight the importance of personalized gut microbiome modulation approaches in different subtypes for optimal therapeutic effect. And I don't necessarily agree with this. They are showing that different subtypes of IBS have different microbiota profiles, but they haven't shown that those different profiles are better treated by a given agent. And therefore, let's say we study 3 different agents. One subtype does good with one agent. The other subtype does better with the 2 other agents. This is still the data that we're missing. And here's one point reinforcing why we should be careful to assume that testing will tell us how to better treat an individual. And here is that study. Looking at, does breath testing, does SIBO breath testing in IBS patients predict who will respond best to a low FODMAP diet? Randomized control trial, small, about 30 patients, who all underwent a lactulose breath test and were then randomized to a control diet or a low FODMAP diet. After 1 week, a low FODMAP diet led to improvements in IBS symptoms. Unsurprising. Here's what is interesting. The baseline levels of hydrogen or methane did not predict who would respond to a low FODMAP diet. What did was the severity of their symptoms, the person and their symptoms. And quoting, assessment of IBS severity, so symptom severity, before the intervention may be used to predict clinical response to a low FODMAP diet. So, to contradict the sort of commentary from the last study saying that, well, because there are different microbiome profiles in different subtypes of IBS, we have to now use personalized therapeutic approaches based upon the testing. Well, That's what they're saying. But then this next study is showing us, well, when we're looking at people who have SIBO and those who don't, it doesn't matter in terms of who will respond better to a low FODMAP diet. But what does matter is the severity of their symptoms. And this, in our practice, is what we try to harp on, which is looking at the individual, their symptoms, their history, and using this to personalize care, not using the labs. Because continuing on or developing from this example, someone may say, well, you don't have SIBO, therefore you don't have to go low FODMAP. And oh, what a miss that would be, because in this study, it wasn't dependent upon SIBO status. It was dependent upon severity of IBS symptoms that predicted who would respond better to a low FODMAP diet. So just trying to continually tie us back to this concept. As interesting as many of these studies are, these lab studies, these tests, they don't really provide a lot of indication for how to better personalize care to the individual. And I want to keep beating that drum because, as you've probably heard me mention in the past, we see so many individuals who have spent thousands of dollars on testing, usually to no benefit and in some cases to detriment. So don't mean to get overly editorializing here, but do want to keep making this point. The next study looked at the low FODMAP diet and compared it to medications. Another randomized control trial. About 450 IBS patients either received spasmomin, it's an antispasmodic drug, or the low FODMAP diet. And after 2 months, essentially, they found equivalency in the outcomes between the low FODMAP diet or the antispasmodic medication. And that's what you're seeing here. And there's equivalency, there is, to be fair, a slight favoring for the low FODMAP diet. But looking at this graph, there's different ways we can interpret this, right? There is an edge for the low FODMAP. I think the difference between the two groups, the low FODMAP and the antispasmodic drug, is fairly minimal, but it is, from a statistical perspective, significant. So there was an edge toward the toward the low FODMAP diet. But as you see here, at time point 4 weeks and time point 8 weeks, both groups are improving. So there are options with a slight edge toward the low FODMAP diet for IBS. And then continuing, how do various interventions improve post-infectious IBS? So you may have heard that one of the things that can cause IBS and can cause SIBO is essentially having a bout of acute gastroenteritis, traveler's diarrhea, food poisoning. And then once that acute bout resolves, there's this residual low-level grouping of symptoms that persists. So this is post-infectious IBS. This study is looking at about 60 individuals, and half of them are either receiving an FMT, a fecal microbiota transplant, or the other group is receiving low FODMAP along with a probiotic blend of Lactobacillus, Bifidobacterium, and Saccharomyces boulardii, plus an antispasmodic medication. And after 3 months, what you're seeing here is there's similar improvements in clinical response rate, IBS symptom severity scores, and fatigue. So either intervention works. This is one of the reasons why my position has been a bit bridled on the use of FMT for IBS. There are some data showing it's beneficial, but my recommendation has been and continues to be to consider discussing this with a clinician once you've gotten to the end of the gut health toolkit. And right here, we're showing some of the starting therapies, low FODMAP, probiotics, and antispasmodics, were able to be as effective as FMT. So they have a time and a place, either one of them, but I would say end of the line recommendation would be FMT for IBS. And a interesting note here, FMT did lead to a greater improvement in dysbiosis. So maybe we can infer from this or take away from this another example of how symptoms and lab findings may not always track, meaning both groups experience similar improvements in their symptoms, but the FMT group had a greater improvement in the dysbiosis. So do with that what you will. And the next study looked at the association between post-traumatic stress disorder in about 180 patients, and did this predict or did this correlate with a higher prevalence of IBS? And it did. They found IBS was diagnosed in 25% of those with PTSD versus 9% of those without. So higher PTSD severity was associated with worse constipation, diarrhea, which this is a newer finding in my mind. I knew of previous research finding that prior trauma, not necessarily PTSD, but prior trauma does correlate with constipation, especially childhood trauma. I was unaware of, but not surprised to see that PTSD specifically leads to an increased risk of diarrhea and of gas and bloating. However, it shouldn't be shocking knowing that there's this bidirectional connection between the gut and the brain and the brain and the gut. So this would be an area that we could help support the brain to gut connection. And things like time in nature, meditation, limbic retraining, hypnosis have all been shown to be helpful, thankfully. So there is a lot that can be done. And the next study, this was fantastic in the journal Nutrients, great journal, a meta-analysis of 6 studies looking at just over 600 patients and examining the effect of vitamin D on IBS symptoms. Now, compared to placebo, vitamin D led to no improvement in IBS symptoms, but it did improve quality of life. So this finding is interesting because obviously it shows that there's no improvement in IBS symptoms when using supplemental vitamin D. However, great job by this group of researchers doing a sub-analysis. And as you see here, when studies looked at those who were vitamin D deficient, so less than 20 nanograms per ml, that's when there was a benefit from supplementation with vitamin D. This shouldn't be shocking in that people who are deficient will respond to a vitamin, or in this case, a hormone, vitamin D technically being a hormone, and those who are not deficient may not benefit. So this helps reconcile what we've discussed in the podcast, which is some studies showing vitamin D supplementation helps IBS, other studies showing vitamin D supplementation does not help IBS. Maybe it parses and breaks down via those who are deficient benefit, and this makes a lot of sense. Okay, coming over to SIBO. This next study looked at, do SIBO patients have higher levels of negative emotions? And this is a really important study. Observational study, small, 26 patients, and with SIBO and 24 healthy controls. Participants with SIBO were more likely to experience stress, large effect size, meaning the magnitude of the impact is large, anxiety, large effect size again, and neuroticism, large effect size. Now, again, I want to be a little bit careful given this is an observational study and it's small. So it's not necessarily the highest quality data point. However, I have a bias here because in the clinic, myself and our clinical team are fairly frequently disheartened at the level of stress, anxiety, fear, and neuroticism SIBO patients come in with. This is part of the reason why I feel it is better to do less testing than more. Part of the reason, because it contributes to psychological burden, if you will, and certainly will not help stress, anxiety, and neuroticism. And as we showed you before, the SIBO testing didn't tell you if you would do any better on a diet as one example. So the SIBO testing, even though it is validated and it can successfully discriminate between healthy controls and those with IBS, it may not be necessary to more successfully treat the individual. So if it's not necessary to more successfully treat the individual, and it may contribute to someone going and spending hours reading about all the ills of SIBO, maybe it's not the best idea to order the SIBO breath testing as you're seeing here. And it's probably a little bit bidirectional, meaning those who have had prior trauma, let's say PTSD, as we discussed a moment ago, may be more likely to develop IBS and SIBO. One direction. The other may be that those who have SIBO may have gut to brain connections, as we've also seen in some research, leading them to be more anxious, neurotic, and fearful. And this has been nicely shown to respond to probiotics as one intervention, which meta-analysis data has found can help depression, and separate meta-analysis help anxiety. But for all these reasons, it's why we want to be careful with how quickly we're just doling out testing. The SIBO breath testing, in my opinion, doesn't tell us how to more expeditiously resolve someone's symptoms, but it does use financial resources and it may contribute to some psychological burden, and therefore we want to be a little bit careful, and I would say quite reserved with the use of SIBO breath testing. A research setting is different. Here, research setting different. Day in, day out, clinical practice, probably not needed. And unfortunately, the field of functional medicine is using tests like researchers, and we really need to remedy and kind of amend this practice. But anyway, moving on. Is there an association between H. pylori infection and SIBO? Observational study in 100 patients. And look at this. SIBO positivity was nearly doubled in those with H. pylori as compared to those without, 60% as compared to 30%. And treatment with H. pylori, quadruple therapy, which includes antibiotics, led to a 40% reduction in SIBO positivity and also improved constipation, abdominal distension, and diarrhea. So one of the nice things here is that as this person, or how I would read this, experienced improvements in their symptoms, their lab findings also improved. I think you can make more of a case for the necessity of testing H. pylori, but consider this. A different meta-analysis has found about a 30% clearance rate, again, using the example of probiotics, of H. pylori when supplementing with probiotics. So perhaps a starting point could be someone presents with symptoms. You're not sure exactly where they're coming from. You use probiotic therapy for a couple months in attempts to resolve their symptoms. If the symptoms go away, I think we can somewhat safely infer that if there was SIBO or if there was H. pylori, you have now addressed that. Now, you always want to discuss these things with your doctor, with your clinician, but this is a framework for thinking that puts the patient's personalizing care to them to resolve their symptoms first, rather than, well, we can't do anything until we do labs. So again, I want to keep weaving this in to try to course correct the field, which is drifted into this very testing-centric practice model. What is the prevalence of SIBO in various GI conditions? Observational study, 186 patients with GI symptoms and 58 controls, all using a glucose breath test. Now, compared to healthy controls, SIBO prevalence was greatest in the IBS-D group, 24% SIBO prevalence in the IBS group versus 10% in healthy controls. Let me pin that to the board for a second. 10% of perfectly healthy controls had SIBO. We should take note of this because, as I've argued for so long, doing a SIBO breath test in kind of this mass screening approach where nearly everyone or everyone gets a SIBO breath test is going to produce some seemingly false positives. Or maybe it's a true positive, but it's somewhat of an anomalous finding, meaning if a healthy control, if a perfectly healthy individual has SIBO, as this 10% did, does that mean that we have to treat it? Probably not. And then also look further at the fact that when looking at IBS total, so including constipative, diarrheal, and mixed, there's no difference between SIBO positivity and healthy controls. And when looking at those who have functional constipation and healthy controls, there was no significant difference between those groups. And when looking at functional dyspepsia, kind of heartburn, GERD type symptoms, there's also no difference between those with functional dyspepsia and healthy controls as it pertains to the level of SIBO positivity. So as someone who's done research in SIBO and again agrees with the test from a perspective of it's valid and it's helpful mostly in a research setting, I'm really starting to rethink the utility of it is sort of in this, everyone who comes into the clinic who has any symptoms or GI symptoms must have a SIBO breath test, because you end up seeing a lot of patients who have symptoms and who are negative, or who have symptoms and who are positive, but then you treat them and retest them and they still have a positive test, but maybe their symptoms have gone away. Or maybe flip that and their symptoms have not changed, but their test is now normal. So the correlation between the two when looking and tracking an individual going forward, I think is questionable. And I think it misses a lot, which is why, again, I'm continually trying to recommend this reservation with how often we use these SIBO breath tests. Because again, in many of these conditions, if you had symptoms or you were healthy, the level of SIBO positivity was the same. And we got to start having this conversation. And then finally here, those with specifically diarrheal IBS, again, had a higher risk of SIBO. But also consider this. We could look at this in a chicken or egg sort of way. We know that rapid motility increases hydrogen. Or said another way, rapid motility can cause a false positive. Now, we also know that SIBO can cause rapid motility. But the point I'm making here is the SIBO testing telling you how to better treat the individual, or by treating their symptoms? Someone has diarrhea. Okay, let's use the therapies that help diarrhea. You're likely going to see the SIBO or the dysbiosis or whatever it is improve as you improve their symptoms. So I want to keep tying us back to, if you use therapies to get someone to know symptoms, you will usually see many things downstream take care of themselves. Leaky gut, issues with mood, issues with sleep, as we've discussed in the past, issues with cortisol, and I would also argue SIBO. Now, we've also discussed the connection between the gut and the liver, knowing that through the hepatic vein, the gut drains to the liver. This meta-analysis of 18 studies found that SIBO was detected in about 35% of those with non-alcoholic fatty liver disease. And even better news, I would submit, is that gut-directed therapies like lactulose, like probiotics, also prebiotics, and even rifaximin have all been shown to improve NAFHD, non-alcoholic fatty liver disease. So you want to bear this in mind, that one of the things to consider if you're struggling with a liver health issue is your gut health. Again, discuss this with your doctor, but just wanting to make this important connection between the liver and the gut. Okay, coming over to GI therapies. This is getting a little bit nuanced, admittedly, but this study is examining which individuals benefit the most from bile acid sequestrant medication. Now, the natural equivalent to this could be something like charcoal or a handful of binders, psyllium, also another one, things that are used to detox, oftentimes detox through bile sequestration. So in this case, a prospective analysis of about 50 patients with bile acid malabsorption or bile acid diarrhea were categorized by underlying cause. Idiopathic, we don't know why. Post-cholecystectomy, they've had their gallbladder removed, or Crohn's disease with an ileal resection, meaning the last section of the small intestine has been surgically removed. And they found that those with Crohn's disease who had the ileal resection had the greatest improvements from the bile binders. So what this tells us, in part, a little bit inferential, well, firstly, is that if you've had your gallbladder removed or if you've had a ileal resection in Crohn's, then bile acid sequestration may help you. And it also tells us that part of what drives diarrhea may be damage to the ileum. And this might be why some of the therapies that help diarrhea. We know that probiotics improve leaky gut and stop with or reduce damage in the lining of the intestine, as do other therapies like glutamine. Probiotics is just one area where there's so much research. It's really easy to use as a proxy for gut therapies. So if we observe in many, many trials that probiotics improve diarrhea, part of what could be happening in some of those individuals is, as it helps to reduce leaky gut, reduce inflammation, the intestinal lining, including the terminal ileal lining, can repair itself, and then, at least theoretically, better absorb bile and therefore reduce bile acid malabsorption, bile acid diarrhea. And you or someone you know or love may have a child with reflux. So this study looks at what effect do acid suppressing medications have on children? Observational study, large study, about 30,000 children who were either prescribed PPIs or who were not prescribed PPIs, acid lowering medication. And the children who were prescribed PPI acid lowering therapy had a 2.6 times higher rate of depression and anxiety. So this doesn't tell us cause and effect. This could be an association. It could be that children who have reflux are eating foods that don't agree with them. Therefore, they're having reflux. Therefore, via the gut brain, they're having depression. That's possible. It's also possible that the acid suppression medication is perhaps leading to malabsorption of nutrients that then cause depression, or maybe are leading to intestinal bacterial overgrowth, SIBO, and that's leading to depression, again, via gut-brain. Whatever the reason, this is why we should really do everything we can to mitigate in children and in adults the use of long-term acid suppressing medication. I think you can make a case for a shorter term, but longer term is really when you want to work with your doctor and say, what else can we do to reduce or eliminate the need for this acid suppressing medication beyond maybe 1, 2, or 3 months? And then the final study, does abdominal massage improve constipation? This was a randomized trial in 40 older adults with constipation, either given control, no treatment, or a lovely aromatherapy abdominal massage using ginger and lavender massaged on the abdomen. And after 1 month, aromatherapy massage led to improved stool consistency and improved severity of constipation. So something to keep in mind if you do have constipation, and this is something that we recommend at the clinic somewhat routinely, is this simple practice of abdominal self-massage. It has been shown to improve constipation and consistency. Okay, so there are a number of studies. I hope this has all been helpful and that you don't mind me weaving in my perspective on testing. The reason why I'm so passionate about continually weaving in that perspective is, again, we just see so many individuals who have done boatloads of testing and it hasn't really been that helpful. And I would also argue for people who've done tests and the tests have been quote unquote helpful, it was likely because they were just doing stuff that would have helped them irrespective of the lab testing. Low FODMAP diet is one example. We discussed a study that found your SIBO breath test results did not predict if you would do better on a low FODMAP diet. Probiotics also don't need a SIBO breath test. Antibiotics also don't require a SIBO breath test, as rifaximin is FDA approved to treat the IBS symptoms. So whether you've done testing and it's been unhelpful, or you've done testing and it's seemingly so been helpful, remember and try to be critical regarding that you may have just gone through interventions and therapies that are known to be helpful for those symptoms, and that testing may not have helped you personalize those therapies any more effectively. Again, all this matters because the thousands of dollars that people can use toward testing may not need to be spent, A, and then B, because many of these tests carry some emotional weight to them. It may be the worst thing, or the wrong thing, I should say, to do for people with SIBO who already have an underlying predilection toward neuroticism, stress, and anxiety. So all of this to help you on your road to better health, better gut health, better global health. And again, as always, this is Dr. Mike Ruscio, and I hope this helps you get healthy and get strong.